So I'll be showing you all the three main maneuvers which you require in upper GI scopy. So the most important thing is your scope should be parallel to the body of the patient. So by seeing the floor of the tongue, just go inside and just focus on this upwheel hand movement. Just do the upwheel down. Just show to the screen. In the screen, what you can see is the epiglottis, ariepiglottis, all those things. And down, the posterior part, what you have is the esophageal opening. So naturally in patients, this esophagus will not be open like this. Either you should go to the right side or to the left side or in the center. So in patients, it will be closed only. Just go to one side, maybe to the left side you go. Ask the patient, just put some air and see will it open or not. If it didn't open, just ask the patient to swallow. When they swallow, what will happen? Naturally it will open up. Once they swallow, just do some slight torque movements and just enter inside the esophagus. Now we are inside the esophagus, you can see the screen. So once in the esophagus, it's just a matter of 10 seconds, you will reach the OG junction. Just keep the lumen in the center, learn to keep the lumen in the center, just push inside. For keeping the lumen inside, you can do your torque movements and just go inside. So one thing is, it's not just about the wheel movements, you should learn the torque movements also. So that even your scope will last long when your wheel movements reduce. So do the torque movements, go inside. So once you reach the OG junction, here comes the next maneuver, because here you are in the OG junction and here you have a lesser curvature like this. So through the lesser curvature you should learn to take your scope. So you have the lesser curvature like this. So for that, what you should do is, as you push inside the scope, simultaneously you should change the position of your left hand, so that your scope will move towards the lesser curvature. That maneuver I will show you. That is the second important maneuver. Just push inside. As you push inside, you see my left hand. I should simultaneously turn the scope towards my chest. See now what happens in the screen. The screen also, it aligned through the lesser curvature, it came to the antrum. So at that time, if you need, you can use your upwheel also to just position it so that it will reach towards the antrum. Once you reach towards the antrum, see, the pylorus is in the center. Now it's just a matter of going inside the pylorus. So while going inside the pylorus in normal patients, sometimes like patients will not they may retch, or they may have their pylorus may be opening and closing. Just ask them to hold their breath for some time, it will remain open. Or you can use the help of your assistant to just push inside and you adjust the wheels. Just go inside through the pylorus into the duodenum. So now you are inside the duodenum. So inside the duodenum, what you can see is, in 90% of the cases, the D1-D2 junction will be almost towards the 3 o'clock to 5 o'clock position. So you know your D1-D2 junction is here, your D2 is here. So what you need here, the maneuver what you need here is, you should go inside to the right side. For that, just ask your assistant to hold the scope mouth end, and you leave your hand from the mouth end. This is one place where you should leave your right hand. Leave the right hand from there, hold it in the small wheel, that is right wheel. Turn the right wheel to right. See, now itself you have almost entered the D2. Second thing, you see my body, you should turn your body to right. See, body and scope should turn to right. See, again, D2 has become better. If needed, you use the up wheel also. You can reposition it. So, classically what they teach everyone is, stand there and right wheel right, up wheel up and turn the body. All cases might not need that. You can, the concept is this. Turn the right wheel to right, the D2 will become visible. Turn your body again, it will be visible. If needed, use the up wheel up so that it will position to the center. Further which, you can push inside. But early cases, even till D2 is more than enough. Then slowly come out, put air, come out. One blind spot in your upper GI scopy is your D1. Because you saw, when you go inside also, you will be pushing it through the pylorus. When you come out also, it will be slipping out. So sometimes, melena cases, you may miss out the ulcers in the D1, especially melena or upper GI bleeds. D1 should be properly evaluated, especially H. pylori related ulcers are very common in D1. So make sure you go inside the D1 again, look all the walls properly so that you don't miss out any ulcers in the D1. And even D1 nets, neuroendocrine tumors are very common. Then come outside. Next, what is pending is the fundus, that is your retroflection. So for knowing the fundus, just focus here. So now your scope is almost in the antropyloric region. Just keep near the antrum in the pylorus region. So your fundus is here. The basic concept is your camera should come here. For that, just keep your upwheel towards you. That means upwheel down. So what happens? The camera is going to face towards the OG junction. Now the scope should come closer. Just pull it like this. That's all. When you pull it, the scope will come. In this you can see the scope will come towards OG junction. In screen you can see the fundus, the OG junction properly. So this is the fundus region. This full is not the fundus. This region is the fundus, and this is the OG junction. The importance of this OG junction is your heels classification is the heels grade 1, 2, 3 for telling how tight the OG junction is. That will be estimated here. So you keep there for some time. Ask the patient not to breathe out, not to retch. Put some air, inflate the fundus, see how tight it is around the scope, and then tell GFE, heels grade 1, 2, 3 or something. And another thing is, when you are examining the fundus, like push or pull. So when you pull, it will come closer. When you push, it will be a wider view. Make sure you examine the fundus properly. Food or water is there, suck it out. Especially in bleeder cases, fundal varices will be missed out. Now you can see the other side also. If for that, just turn the scope like this. When you turn the scope like this, you can see the other side. That is to see the lesser curvature side and the greater curvature side. So fundus is important for varices, for OG, commenting about the OG junction, for fundal polyps will be the hyperplastic fundal polyps will be the, or like gastric neuroendocrine tumors can be the. So fundus is very important for them. Now, when you're coming back, one more hidden secret is there. So when you're coming back, many times what we tend to do is we'll be just pulling it outside. So rather, you must closely see the greater curvature. What you see here is the greater curvature. When you're coming back, come to the greater curvature, come to the cardia region. This is the cardia region. You should make sure you examine the cardia properly before you pull it out. Because when you go inside, you will be doing the manual. You will miss the cardia. When you come out, just pull it slowly, see the cardia region. That is just beyond the OG junction. Here, examine it properly, because see that lesion which was not previously visible properly. Now it's visible. So see that properly, then come out. Finally, when you come back, you should measure the distance between the Z line and the diaphragmatic pinch, because that will tell you about hiatus hernia. So, for example, if this is the Z line, yeah, this one is the Z line, and this will be the pink mucosa, etc. This will be the diaphragmatic pinch. So, if it is more than 3 cm, especially 2 or 3 cm, more than 3 cm, you will tell there is sliding hiatus hernia. Then slowly, so finally, after measuring this, just go once more inside, suck out all air. Otherwise, post-procedure in your OPD patient will be sitting and retching out. Suck out all air, come out, see the esophagus properly. When you went inside, you haven't seen the esophagus properly. See the esophagus properly, see it, slowly pull out. This region, that is the upper esophagus, that is immediate post-cricoid region, is the place where you miss squamous cell carcinoma. Squamous cell carcinoma is most commonly in the upper esophagus. It will be a small ulcerated lesion. When you pull out, don't pull it out like immediately, because patient may retch. But put air and slowly pull it out. SCC, you may miss it out. The inlet patch is there, but that's not always pathological. Just slowly pull it out and come out. This is the full steps of an upper GI endoscopy. So when you practice, try to practice the intubation, this manual, retroflection, D1.